Hello again, everybody. We are going to talk here about orthopedic disorders of the distal upper extremity. And the distal upper extremity, or the forearm, is composed of two bones, the ulna and the radius. The ulna articulates with the humerus at the elbow, and then the ulna and the radius come together at the distal radio-ulnar joint in the wrist, and then articulate with the carpal bones. So we're going to just do a quick anatomy review before we then talk about the fracture of the ulna, which is the Monteggia's fracture. And this is the most common fracture of the ulna, which occurs at the proximal one-third of the ulna. And then we'll talk about some various fractures of the radius, as well as a dislocation of the head of the radius, which is known as Nursemaid's elbow. So just a quick anatomy review here. We have the radius and the ulna. The ulna is going to be medial, the radius is going to be lateral. And the ulna is the bone that gives us the olecranon process, which is the process that articulates with the humerus, with the distal portion of the humerus. So this is going to be important. This is our elbow joint. And the medial and lateral epicondyles sort of hover over this bone. So you've got your lateral epicondyle on your lateral side here, and then your medial epicondyle is just slightly superior, proximal, and then medial to your trochlea, to your olecranon. I wouldn't worry too much about the anatomy of the bones, but it is useful to know that for the radius, the head is proximal, it's up at the elbow joint, whereas for the ulna, the head is distal, it's at the wrist. So when you hear the head of the radius or head of the ulna, they're really at two different points. The head of the radius is at the elbow, the head of the ulna is at the wrist. Okay, so just looking at this a little bit in greater detail, we're going to talk about 5 different pathologies here. We're going to talk about a Monteggia's fracture, which is a fracture of the ulna, and then focusing on the radius, we'll talk about Nursemaid's elbow, which is a distal subluxation or dislocation of the head of the radius. And then we'll talk about Galeazzi's fracture, which is a fracture of the distal radius. And then finally, we'll finish up talking about Colles and Smith's fractures, which are fractures of the distal radius, approximately 1 inch from the articulation of the radius and the ulna at the wrist. So Monteggia's fracture is a fracture of the proximal one-third of the ulna, and it's accompanied with dislocation or instability of the head of the radius. So because these two bones are so close to one another, when you get a fracture of one, you generally get some level of dislocation in the other. So you really can't have one without getting, you can't have a pathology or a break in one bone without getting some kind of problem in the other bone. So this Monteggia's fracture is the two of these together. It's a fracture of the proximal one-third of the ulna, but also a dislocation and instability of the head of the radius, coming disarticulated with the elbow joint. So the most common cause here is a fall on an outstretched hand, and this is going to be pretty much the cause of all of these fractures that we're going to talk about with the forearm. Symptoms are pain and swelling of the elbow, and for fractures, the rule of thumb is pain and swelling are the symptoms that are most prominent. You have that pain and swelling just because you have a fracture of the bone, which results in inflammation, and that's going to cause pain, and it's also going to cause a localized swelling. You'll also have a decreased range of motion, and that decreased range of motion is due to two things. It's due to the fact that, yes, you have a bone breakage, but you also have a dislocation of the joint. And so if the head of the radius is not articulating properly, then you're not going to be able to move your elbow as normal. So we have pain and swelling and decreased range of motion. Sometimes you can palpate the radial head, although that may be difficult depending on the patient, how big they are, and so forth. What you want to do with a Monteggia's fracture, because the elbow is such a small space, such a small cavity, What you want to do is you want to make sure that the fracture is not open, because that's going to dictate how you treat the patient. If the fracture is open, the only treatment that's available is going to be open reduction with internal fixation. And we're also going to make sure that the patient has to be on antibiotics because they're at risk for infection of that open wound. If the fracture is not open, in some cases you'll be able to do closed reduction, but not always. We'll talk about that when we get to treatment. So first off, make sure that the fracture is not open. Secondly, what are the nerves that are affected with Monteggia's fracture? Well, it tends to be the radial nerve. So the radial nerve is most often affected. This is a nerve that supplies the wrist and finger extensors. So think of the posterior compartment of the forearm. And so there's really two nerves, the radial nerve and then the posterior interosseous nerve, which travels in between the radius and the ulna. The posterior interosseous nerve is actually a branch of the radial nerve. The best initial diagnostic step is going to be an X-ray at the elbow, and that's really the best initial diagnostic step for any fracture, so this isn't really different here from anything else. And it's very important, anytime you have a fracture, to make sure you've got at least 2 orthogonal views. Now remember, there's up to 3 orthogonal views that we can get. We can get an X direction, a Y direction, and a Z direction, 3 dimensions. We want to have at least 2, because if you just have one direction, you can't really see what direction. If like for instance, you have an AP X-ray, you can't really see if it's anterior or posteriorly dislocated, because it's a 2-dimensional X-ray. So you're going to want to have a lateral X-ray as well, so you can see what direction you have dislocation at. That's going to be able to assist the surgeon when they do the reduction, be it closed reduction or open reduction. So at least 2 orthogonal views. The treatment here is going to depend on age. So in skeletally immature patients, which is generally less than 16 years of age, the rule of thumb I would use for the USMLE would be in a pediatric patient. You can use closed reduction and casting, and that's generally the treatment of choice. In adults, open reduction with internal fixation is usually necessary. So with fractures of the forearm, for the most part, the decision making as far as whether it's closed reduction or open reduction is going to be based on age. Remember, of course, that if the fracture is open, as I previously mentioned, that open reduction and internal fixation is always going to be necessary regardless of the age of the patient. And with Monteggia's fracture, open fractures are quite common. So this is an X-ray of the forearm, just to sort of familiarize yourself, refamiliarize yourself. So this is a lateral X-ray here on the left. And here we have the articulation between the humerus and the ulna. And then we've got the radius here and the ulna, which then come together. Where they come together is called the distal radial ulnar joint. So important to remember that the radius and the ulna actually articulate together. They're 2 bones, they're separate, but they come together distally. And then this is a AP image here on the right. Now we compare this to a Monteggia's fracture. So clearly here we've got a fracture of the ulna, and then that fracture has caused the radial head to dislocate from its articulation with with the ulna and the humerus. So these are 2 things we see. With Monteggia's fracture, we see a fracture of the proximal ulna and a dislocation of the radius, the radial head. And then this is just a normal X-ray here, so you can see there's a clear difference. Here's another one. Again, this radial head, of course, should be down here. And really, with Monteggia's fracture, I should add that usually it's the proximal 1/3, but it can really also be the distal 1/3 here, as you can see. Or distal 1/3, so proximal 2/3. And then here's another one. This is obviously a severe case. This one's pushing out the skin. You probably know this would be an easy radial head to palpate. So you see varying severities. This one not as severe as this one. And that's a good thing to recognize, that with fractures, there's a whole range of severities. So you're not always going to have the same severity in one patient as the next. Okay, nursemaid's elbow. So now we're talking about the radius. So everything from now on is going to be either a dislocation or fracture of the radius. So nursemaid's elbow is seen exclusively in pediatrics. And what nursemaid's elbow is it's a subluxation, which would be like a partial dislocation, or just a frank dislocation of the head of the radius. Now, the head of the radius is held in position next to the ulna and the humerus by the annular ligament. And the annular ligament, as with all ligaments in children, are a little bit lax. And so we see this with children that if you have this sudden or heavy tugging on their arm, you can actually cause the head of the radius to come out of the annular ligament and slip out. So think about what would cause sudden or heavy tugging on the arm of a kid. Those are things that would usually happen to a kid. I mean, you're trying to pull the kid along. You may even be pulling their arm out of a jacket sleeve, something just as benign as that. These can actually cause this problem. So this isn't something that even necessarily has to be traumatic. It may just be something really minor, and it can actually cause the head of the radius to pop out of that ligament. So remember that with children, they do have very lax ligaments, and nursemaid's elbow is a problem of the radial head in relation to the annular ligament. So what we get is a dislocation because it slips out of that ligament and is no longer held in place to both the ulna and the humerus. So the symptoms here are going to be pain and tenderness over the elbow. You tend to not see swelling as much, although you can if it's more severe. But generally, this is going to be a child that has acute pain of the elbow and no significant trauma. This is not something that's caused by falling down, falling off a bike or something. It's caused by a parent maybe pulling their kid if they're not following along. They pull their kid by the arm. Not an abusive situation. It's just something that parents may do. So you'll see this quite commonly. Now, the kid will usually be able to move their arm. They may resist because they're in pain, but the one motion that they will definitely resist and that they'll be in pain in if you try to move their arm in that direction is supination. So moving the hand, if you're holding your hand with your palm facing down, moving the hand so the palm's facing up. That's going to cause significant pain in the patient with nursemaid's elbow. And the reason for that is because with supination, you have significant movement of the radial head. And if the radial head is dislocated, you're going to have the radial head moving up against all sorts of structures, and so that's going to cause pain. So look for a kid with pain and tenderness over the elbow with no history of significant trauma. The diagnosis is going to be clinical. A lot of times the patient's parent, family member, caregiver is not going to know what caused this because they pull their kids' arms all the time. I mean, you're holding your kid's hand, you're pulling them along with you. It's nothing severe. So it's not like falling down off your bike or anything. So a lot of times the parent's not going to know what caused this pain. But you should know, and it's very important that you know that this is a common thing that happens in kids, and it should be your number one on your differential for elbow pain when there's no history of trauma. Obviously, if there is a history of trauma, we're concerned about fracture, but with no history of trauma, definitely think nursemaid's elbow. And the treatment for this is closed reduction. So we make our diagnosis clinically. What we then do is we attempt the closed reduction. If that doesn't work, then we can get X-rays of the elbow to see if it's really a fracture. But this diagnosis is made clinically. So on the USMLE, if you're given a vignette of a patient that's consistent with nursemaid's elbow, your next step is going to be closed reduction. You're going to be putting that radial head back into place. And the way you generally do that is by moving the arm into supination and then applying some axial compression pressure on the arm, and that will usually slip the radial head back underneath the annular ligament. So this is sort of the motion that causes the nursemaid's elbow. And you can see here, again, this is not abuse. This is something that parents do, and they don't realize that they shouldn't do it, but it happens. And then this is what sort of happens if you look at the sort of a schematic here. So this is the annular ligament. It holds the radius in place to the ulna, and what happens is the head of the radius kind of slips out of that annular ligament. All right, a Galeazzi's fracture is basically like almost a total opposite of a Monteggia's fracture. So whereas a Monteggia's fracture is a fracture of the proximal 1/3 of the ulna, the Galeazzi's fracture is a fracture of the distal 1/3 of the radius, and it causes dislocation, instability of the distal radio-ulnar joint. So your joint, where the radius and the ulna come together, the radius and the ulna should be relatively close to one another, if not right next to each other. What you have in Galeazzi's fracture is the radius and the ulna distally will be separated, and that's called distal radio-ulnar joint dislocation. DRUJ dislocation. And that will often be noted on x-ray. It'll be clear as day when you see it. As if the fracture shouldn't be clear. You'll notice that dislocation. So again, with Monteggia's fracture, we have to have the two. We have to have the fracture plus the dislocation. With Galeazzi's fracture, you also have to have the fracture and the dislocation. So a fracture of the distal 1/3 of the radius plus dislocation or instability of the DRUJ. The most common cause is a fall on the outstretched hand. And the symptoms are going to be pain and swelling and a deformity over the wrist. Why a deformity over the wrist? Again, with a wrist, you're talking about a really small space. So if you have any kind of dislocation, you're going to notice it because it's a small space. So if you notice a deformed wrist, then think of a dislocation of the radio-ulnar joint. For diagnosis, again, you're going to want to have at least 2 x-rays at the affected site. And then the treatment is the same as Monteggia's fracture. If it's a skeletally immature patient, you can do closed reduction and casting. In adults, open reduction and internal fixation is usually necessary. And again, if it's an open fracture, you're going to have to do a open reduction and internal fixation. So here is a Galeazzi's fracture. And you can see here that even though you don't notice it on the AP X-ray, you can see that clearly the ulna has become dislocated from the radius. These two should be nice and snugged up together, and the ulna here has become dislocated. And then here's your fracture. Here's another one. So here you can see more of a lateral medial dislocation of the ulna, whereas this one was more of a posterior dislocation of the ulna. It doesn't really matter what direction the ulna is dislocated, just that it's dislocated. And you can see also that there is a distance here in this AP X-ray between the radius and the ulna. They should be relatively close to one another. All right, a Colles fracture. So now we're going to talk about 2 different fractures, Colles fracture and Smith's fracture. These are the last 2 we're going to talk about here. And the Colles fracture is a fracture of the distal radius, and this is within 1 inch of the distal radial ulnar joint. And what happens with a Colles fracture is that we have a fracture of the distal radius, but then there's a deviation of that distal piece. So with the Galeazzi's fracture, we have a dislocation of the ulna. With a Colles fracture, the dislocation is at the radius. So you have a fracture of the radius plus a dislocation of the radius. With Galeazzi's fracture, it's a fracture of the radius and a dislocation of the ulna. So fracture of the distal radius plus dorsal deviation of the distal piece of the radius, which is the smaller piece. And the most common cause of this is a fall on an outstretched arm with the wrist in an extended position. So if you have your wrist in an extended position, what side is going to be impacted? It's going to be the ventral wrist. And so if you have the ventral wrist that's being impacted, it's going to shove that radius posteriorly. It's going to shove it dorsally. And that's why we get dorsal deviation of that distal piece. We do see an increased incidence of Colles fracture in osteoporosis, and the symptoms of Colles fracture are going to be the same that we see in any fracture: pain and swelling and tenderness over the wrist. Again, with Colles fracture, just like the Galeazzi's fracture, because this wrist is such a narrow, tight space, if you have any kind of dislocation, you're going to see a deformity. So what you see is this classic dinner fork deformity, and that's kind of a strange association, but I'll show you what it looks like, and you might be able to see how it does kind of look like a fork. The best initial diagnostic step, this shouldn't be news to you, is going to be an X-ray at the wrist. You want to have two views, and you're going to need it to see if this is a dorsal deviation or a ventral deviation, which, as we'll see, is known as Smith's fracture. And then the treatment is going to be closed reduction and splinting or open reduction and internal fixation. This is going to depend on the degree of dislocation. So just to compare Colles fracture and Smith's fracture, which we'll talk about, really the only difference is that a Colles fracture is a dorsal dislocation of the distal piece, and a Smith's fracture is a ventral dislocation of the distal piece. Other than that, they're the same thing. So here's a Colles fracture. This is called the dinner fork deformity, and this is the dorsal side and this is the ventral side here, and you can see that you've got this sort of this deformity where you've got this prominence on the dorsal side. And what it kind of looks like is a dinner fork where you've got this long side here, and then you've got this prominence kind of here at this neck, and then you've got the fork part, which would be like the hand. I don't know. It's not the best analogy, but the USMLE loves to say dinner fork deformity for one reason or another, so I would remember that. But this is the Colles fracture deformity that we classically see. Sometimes it's called a bayonet fracture. I don't know. I don't even know what a bayonet is. I think they use it in war. Okay, so here's Colles fracture on X-ray. So you can see on the anterior-posterior view, you can't really see any dislocation because the dislocation for Colles fracture is dorsal. So if you're looking anterior-posteriorly, you can't see that direction. You can't see that dimension. You can only see in the X and Y direction. So all you can see is the fracture of the radius. So here's our fracture right here. But then if you look at the radius, what direction it's dislocated, you can see it's clearly dorsally dislocated. And if you could see the rest of the hand, you would see that this is the dorsal aspect of the hand. That may be difficult to notice otherwise. So here's another one. This is a lateral view, and you can see both the fracture of the radius as well as the dislocation of the distal piece right here, and it's dorsal. And you can also see that kind of dinner fork deformity right here. Okay, and then here's another one. Again, fracture at the radius, and then a dislocation of the distal piece dorsally. Now, a Smith's fracture is just a reverse Colles fracture, and a lot of times you hear it referred to as a reverse Colles fracture. And it really is. It's a fracture of the distal radius, but in this case, rather than having a dorsal deviation of the distal piece, you have a ventral deviation of the distal piece. So the cause of a Smith's fracture is the exact same as a Colles fracture, except rather than falling on your wrist in an extended position, you're falling on your wrist in a flexed position. And so because your wrist is flexed, when you fall down, you're hitting the dorsum of your wrist. And so when you hit the dorsum of your wrist, it's going to shove that broken piece, that distally broken piece, ventrally rather than dorsally. So if you can imagine, if you strike your hand, if you strike your wrist dorsally, you can see how clearly you're going to push that piece ventrally. So an impact at the dorsal wrist. And the symptoms are going to be pain and swelling and tenderness over the wrist, and a lot of times you'll also see a deformity, although it's not that classic dinner fork deformity that we see in Colles fracture. Diagnosis, again, is going to be X-ray at the wrist. You're going to want to have at least two directions, and then the treatment will be depending on the degree of dislocation, so closed reduction or open reduction. And then here's the Smith's fracture. So it looks just like the Colles fracture, except that the distal piece is dislocated ventrally rather than dorsally. So we don't have that dinner fork deformity. Remember that if you feel your own wrist, and you can feel that on the dorsal part of your wrist, there's really no space between the skin and the bone. And so that's why with Colles fracture we get a prominent, we get such a prominent deformity, because if the bone of your radius, of the radial head, becomes dislocated dorsally, it's going to poke right out. It's going to protrude. But if it becomes dislocated ventrally, well, there's a little bit of room for it to go, and you might not notice a deformity. So ventral dislocation, rather, right here. There's another one. You look at the AP view, yeah, you can see the fracture of the radius, but you can't see the direction it's dislocated in. Then you get the lateral view, and you can see that there's a ventral dislocation. And then another one, again, here, it looks like you also have a fracture of the ulna, too. But here's a fracture of the radius, and then the ventral dislocation here in the lateral view. So always, 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 can't stress it enough, if you've got a patient where you suspect a fracture, get 2 orthogonal views.